Welcome to San Francisco. This is eCancer. My name is Noel Clarke. I'm a consultant urological surgeon from Manchester in the UK and Professor of Urological Oncology at the Christie Hospital in Manchester. And I'm joined by Eric Small, a medical oncologist and a friend of long standing who we've known each other for many years. We're here at the ASCO conference in San Francisco, and one of the highlights of the conference has been the presentation of two large-scale multi-center randomized trials looking at novel anti-androgenic treatments in men with non-metastatic castrate-resistant prostate cancer who've got rising PSA. These are the PROSPER and SPARTAN trials. Eric, do you want to just talk to, give us a brief thumbnail sketch of what that trial has involved?
Sure. And probably it's fair to say this is a thumbnail sketch of both trials because they were remarkably similar in design. As you know, this group of patients is one for whom there is no standard of care. These are patients that we know will develop metastatic disease. They're castrate resistant and they're considered high risk as identified by a very short PSA doubling time. These patients are assumed to have micrometastatic disease, and indeed untreated, as in historic studies we've seen a significant number of patients develop metastases. So the principal goal for both of these studies was metastasis prevention. And because second generation antiandrogens or androgen synthesis or signaling inhibitors have been shown to have activity in patients with metastatic castration-resistant prostate cancer, it was a rather simple decision to make to test patients with non-metastatic disease who are at risk for progressing. The design of both studies was to randomize patients at high risk of metastases to receive either the active drug, apalutamide, or enzalutamide versus placebo. In terms of the SPARTAN trial, we randomized, actually it was between both studies, 2-to-1 ratio to receive one of these agents in conjunction with ongoing androgen deprivation therapy. The primary endpoint of these studies was metastasis-free survival, essentially looking to see if metastases could be prevented. And then there was a number of secondary endpoints. On the SPARTAN trial, we were very interested in endpoints proximate to overall survival, so symptom management, what we've termed progression-free survival 2, progression after the next treatment.
It was nice to see the matching of the populations. I thought that it was striking that there were large-scale, 1,200 and 1,400 patients, roughly speaking, and that you'd both dichotomized your PSA in pretty much the same way, which is less than 6 months and 6 to 10 months, based on the information which came from the old denosumab study about the development of metastatic disease at that inflection point at about the 10-month PSA rise point in M0 castrate resistance. But looking at the characteristics in both of the studies, many of the patients were good prognosis, should I say good performance status patients. About 80% were performance status 0, about 20% performance status 1. So whilst that's representative of a population with prostate cancer patients, one of the questions that's been raised is the rationale for treating these just on the basis of rising PSA.
Right.
I guess we might have some differences across the Atlantic as to how we would approach a patient like that.
Yeah, I think the issue, so you raised two very important points. The first is not all climbing PSA patients are the same, and that even if they're all castrate resistant. We know from, as you say, the old denosumab data, who are the patients that are destined to die from their disease and to develop metastases. So it's important to note that both studies selected patients who are at very high risk of developing those events. I think the data from both studies is fairly incontrovertible. There's no question that using apalutamide or enzalutamide delay the time to metastasis. I mean, the data is fairly compelling. It's a very strong hazard ratio. P-value of 0.0001 in both studies. Really impressive impact in terms of what we saw. In the SPARTAN study, we saw a 2-year delay in time to metastasis for people who got apalutamide versus not. So I don't think there's going to be any discussion or argument about are metastases prevented. There's no question that they are. I'll come back to the performance status bit in a second. I think the appropriate question is, does that matter? Does it make a difference in terms of the final outcome for these patients and how they do? And there's a number of different ways, I think, of answering that. First of all, on the SPARTAN study, it's really important. I mean, we're very delighted to see that every endpoint, secondary endpoint, was met in addition to metastasis-free survival, and most importantly was symptomatic progression-free survival. So we were able to delay the time to bone pain and the time to the need for bisphosphonates and so on and so forth, skeletal-related events. So that delay, for me, speaks to an important clinical benefit, even if you don't believe that delaying metastases in and of itself. I think if you were to ask, again, it depends on what side of the Atlantic you're on, perhaps. I think if you were to ask one of my patients how they would feel about delaying the time until when they had metastases, delaying by 2 years is a pretty good thing to do. The other component of both of these studies is that both showed a trend, but not a significant trend, towards improvement in overall survival. I wouldn't take that to mean that there is or is not going to be. There's only been 24% of all events in the SPARTAN trial before we can even begin to look at survival. That said, with 24% of events in place, hazard ratio is 0.7, p-value is 0.07. It appears that at least the trend is in the right direction. The only other thing I will say, and we can't predict what the ultimate survival will be, of course, but the only other thing that I would say that on the SPARTAN trial, we went out of our way to try to ensure that patients were treated with standard of care at the time of developing metastases per labeled indication. So the study actually provided abiraterone to those patients who had reached the primary endpoint and whose physicians wanted to provide it to them. It was not mandatory, and so not all patients got it, but 80% of patients on the placebo arm received approved therapy, i.e. life-prolonging therapy, and of those, the vast majority, no surprise, were androgen signaling inhibitors, either abiraterone or enzalutamide. So what we have, therefore, is a study where all of the vast majority of the placebo patients have already been treated, have already received appropriate therapy. And so this is going to be, once we look at the survival data, a true study of early versus delayed therapy, as opposed to what we wanted to avoid, which is early versus never, right? The survival data might look better if some patients had gotten apalutamide and the control group had gotten nothing. So we're very glad about that piece of it, but you're right, we have to wait for that data to mature.
Yeah, I mean, that's a fascinating issue, I think. So the question of early versus late, and one of the points which was brought up by Philip Kantoff, who was the discussant in the poster session, or the podium session to discuss the posters, was what drives those decisions to treat.
Yeah.
So a question which remains unresolved is, in those patients who develop metastases, and they clearly did that sooner in the placebo arm, did it make any difference because they then got treatment? It didn't obviously make a difference to survival. And one of the things...
Not yet.
Well, not yet, and I accept that things are immature, and patients will need to be followed longer. But of course, remember that in both trials, the age of presentation of the patient was in and around 73, 74.
That's correct.
The average life expectancy in the UK of a 74-year-old is 10 years, roughly, 10 to 12 years. And it's probably the case that in an individual with advanced prostate cancer developing from a certain point, their survival is 5, 6, maybe 7 years, and it will be longer in some, according to comorbidity. But coming to the point, it is that, the early versus late question, the quality of life information which presented in your trial, it wasn't presented in the enzalutamide trial.
Right.
I'm told that it is to be presented and has been collected, but it didn't change. Now, there are two things in that. One is that the quality of life in the placebo patients didn't go down appreciably, but equally the quality of life in the treated patients didn't go up either. Now, if patients are having a treatment, then we like to think that it's going to improve their quality of life.
I would counter that. I think Phil Kantoff raised a very important point, which is how sensitive are these instruments to pick up these kinds of differences. What we were able to see, in fact, was this benefit that we're seeing in terms of metastasis-free survival, progression-free survival, symptom progression-free survival, symptomatic progression-free survival, was not done at the cost of side effects. So, in fact, we were quite delighted to see that patients started very high quality of life, and you started off by saying this, these are good performance status patients, and in general, patients with non-metastatic disease don't have symptoms in general from their disease. They may have some symptoms from androgen deprivation therapy, but by and large, this is a relatively healthy, relatively asymptomatic group of patients. So I think that any treatment that's going to be used in this setting had best be non-toxic if it's going to have any utility whatsoever. In other words, we could delay the time to metastases, but if it's done at the expense of substantial quality of life decrement, then it's absolutely a non-starter. What we saw with two different instruments was that patients, in fact, did not have a decrement in their self-reported quality of life. So it's hard to improve on starting well. So the absence of seeing improvement doesn't worry as much. That doesn't worry me as much. I am relieved that there wasn't a decrement. There was a question somewhere along the line about, oh, well, maybe we should be thinking about combining in this group of patients Taxotere together with apalutamide or enzalutamide, sort of taking non-cross-resistant agents. And I think there you really start worrying about quality of life impact. At least with these agents, I really can't speak to the enzalutamide study because it wasn't reported. But at least in the SPARTAN study, there was no decrement, and I think that's very positive.
Yeah. There were some side effects, though, I think it's fair to say. There was an increase in cardiovascular side effects. There was a small increase in the enzalutamide, and I suspect in yours as well, in mental function. Both had a small but significant number of epileptic fits in the treated group. So there is a downside to it, but one of the things which was raised, and subsequently it was raised in a presentation afterwards in relation to cost-benefit from the STAMPEDE trial, and that is if these patients are going to be treated for quite a long time with relatively expensive drugs, what's the cost benefit? Can the healthcare systems afford it?
Yeah, and that's a excellent question. I can't tell you at all what the cost will be of apalutamide, so it's hard to do that analysis quite yet. Sort of, Nick James' approach to it, which is a way of looking at it, is that the longer you keep people in the non-metastatic setting, yes, you do have some of these adverse events to deal with, but the longer you keep someone in the non-metastatic setting and keep them out of the metastatic setting, that there's potential benefit from that and gain from that. And it has to be evaluated, it has to be measured. I do want to say one thing about toxicity. Having used this drug, at the end of the day, 8 to 10% of patients dropped out for side effects. So it was not substantial. And really, if you look at the individual side effects, it was, in my estimation, very well-tolerated therapy. The epileptic fits, the seizures, were seen in 0.2% of patients, not zero, and there's no question that that's a class effect. Right. We've seen this, and I think it's true for both drugs. I don't think it's a common event, but certainly in the case of the SPARTAN study, both cases were explainable. One patient had a pre-existing condition and one patient had a traumatic fall, but nevertheless, it's a real event and something that we absolutely have to be aware of and tell our patients about, no question. The other thing that I want to point out, which was discussed a little bit in the context of the enzalutamide study, was this, and I think there'll be more data coming out, that the preliminary data that Dr. Hussain presented suggested that 15% of patients, sort of a stunningly high number of patients on the enzalutamide arm died without metastatic disease. A second issue really is, in terms of the tolerability of these agents and potential significant side effects, is what is the proportion of patients that are dying from events that are not prostate cancer related. I can't speak to the enzalutamide data except for what was presented by Dr. Hussain. On the SPARTAN study, it was 1.1% of patients. So that's encouraging that we're not having patients die of things other than prostate cancer. Yeah. That would be very distressing, I think.
Yes, and I think that in the presentation that Dr. Hussain gave on the enzalutamide data, which was picked up by Dr. Kantoff, I think there was a misconception because this figure of 15% came out. And of course the audience, of which I was one, all sat up and thought, well, this doesn't sound very good. But actually, when going down to see the data and speaking to the people who ran the trial, in fact, this was patients who had not developed metastases on the treatment arm, who died from other causes.
Right.
And the view was that they had naturally had an extended period of life and died from something, cardiac event or whatever.
Sure.
And that is explainable in terms of the natural life expectancy of individuals. As we mentioned earlier, the average age 74, so some of them will have been older. And one has a natural lifespan, and that explains that reason. So I suspect that that was a misconception in terms of the presentation.
There's no question that one needs to, and we'll see it once they publish their data, that one needs to see the data corrected for duration of exposure. So the patients, as you say, the patients who are on the treatment arm, on the active agent, live longer or are exposed to drug longer, and so are subject to many more of the typical side effects that you'd be looking for. I think that's going to be really important data to look at.
So a big question, I guess, is in the US, is this population of patients going to be receiving treatment much earlier? In other words, are we going to be adopting enzalutamide or apalutamide in the metastatic, in the M0 castrate-resistant space? Yeah. And I guess the question I have unresolved for myself is, what will happen in Europe and other parts of the world?
Well, that's the 85 million pound question. I don't know the answer to that. I mean, some of it obviously depends on the regulatory authorities. Is this going to be approved by the FDA? We know that the companies have submitted the data for consideration. I have no way of knowing what will happen. But making the assumption that it is approved, the question then becomes, is this something that is likely to be adopted readily? And as I don't know. I think that in this country, there's a lot that is driven by patient request and expectation, and as Maha Hussain pointed out, it requires an individualized discussion between physician and patient to understand potential risks, potential benefits. I suspect at the end of the day, and obviously once survival data come out, that changes things altogether, because if earlier treatment prolongs survival, then that will be a less difficult decision to make. Yeah. That's many years down the line. So based on this, I suspect that delaying metastases for 2 years, delaying symptomatic progression will probably carry the day. And I suspect that for patients that have particularly aggressive disease, whose PSA is climbing rather rapidly, I suspect it's going to be adopted, but it really remains to be seen. The other sort of unspoken thing, and I know you would agree with this, is we have the luxury in the setting of a study like this or in an academic setting to calculate a PSA doubling time. Many clinicians don't, right? And will be extrapolating or flying by the seat of their pants saying, oh, well, the PSA last month was 0.2 and this month it's 0.5, ergo. And that would be a mistake, because we know that 1 or 2 PSA values don't determine by any means what the trajectory will be. It is very clear in my mind that patients with a very slow PSA doubling time do just fine being watched.
Yeah. I think that if I might conclude, by congratulating you and Maha and the teams from the 2 trials, because we have clearly got active agents. We've got data from 2 extremely well-conducted trials. It gives us a problem of how to sort out who to give it to and when, and this will be resolved in the fullness of time. But for sure, it's been fascinating to pick up the data, and we will be going through it for some time yet.
I suspect we will be, yes.
So that's all we have to say from San Francisco. Thank you for listening. It's been a great pleasure. Thank you.